Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai and Professor Ramon from Barcelona, Spain. It's really great honor for me and for our organization, for Global Laparoscopy and Robotics, to have such a legendary professor. Sir, as you know, we have started this series of interviews with MGB, OAGB in 2021. That was for 6 months. Then we continue. At that time, we started with Robert Rutledge and Professor Carbau and all big names of who are practicing actively MGB or OAGB, or most of them were hybrid technique. So then we followed for 6 months safe sleeve gastrectomy. And in this year, so from Feb 2022, we have started Roux-en-Y gastric bypass by Professor Himpen. And now we are continuing this series, and it's really great honor to interview such a prestigious figure. Sir, over to you.
Thank you very much for the kind invitation. And for me, it's also an honor to be interviewed by your organization and by all the effort and work you are doing to diffuse all the knowledge on the bariatric science, which I think is very important for to use this approach and also to understand the different techniques that could be more convenient for each patient. So thank you very much for the kind invitation.
Sir, so much thanks. It's really great honor because our target is to sharing knowledge, so sharing experience. If we compare with the webinar, in webinar, we have not such a time, maximum 5-10 minutes, and we cannot explore completely. So this was the main theme behind this interview series. Now we have sufficient time, and we have divided these questions main in 3 sessions, some pre-op, technical points, and also post-op. And our questions are basic questions because most of our viewers are youngsters and our target is our youngsters. So due to this, so our question base is basic questions. So sir, first of all, so we are interested to hear from your side, your brief introduction, your journey of bariatric surgery and journey of Roux-en-Y gastric bypass.
So I come from Barcelona, and I started my bariatric practice in 2008. So then I got involved in my hospital, directly in the bariatric field, in which we had a hospital with around 200 cases per year. So I started with my Roux-en-Y gastric bypass, but also I took the tsunami of the sleeve. So, so that was very interesting. But then I in 2013, I moved 2 years to Belgium with Dr. Himpens, where I learned a lot of revisional surgery. I got trained in robotic by Carlos Bath and Kate Kim in the United States. And then I introduced the robotic surgery in my hospital in 2010. So we started performing sleeve gastrectomy, then gastric bypass, and now we recently even published the first series of revisional surgery, where it's maybe where we can put the focus on the robotic platforms. So now I've turned back a lot to the OAGB and gastric bypass. We have denied a lot of the sleeve gastrectomy. We are facing a lot of long-term complications like GERD, hernia, and especially GERD, with a high rate of conversions. And that's the reason that, and I'm sure we are going to discuss the indications, but if a patient can have a direct gastric bypass, we try to afford him a gastric bypass.
Sir, excellent and great achievements, and definite now more than 1 decade. So you are practicing bariatric surgery. So because today we will discuss about Roux-en-Y gastric bypass according to your experience. We know many of us know about data and guidelines, but definitely when someone like you who is practicing more bariatric, definitely you also have some red lines for yourselves and also gray area. So what is the relative and absolute contraindication of Roux-en-Y gastric bypass?
So in our institution and in my own practice, the Roux-en-Y gastric bypass for us is the gold standard. But if we can define patients with a minimum of metabolic comorbidities. We like to do gastric bypass in metabolic patients ranging from 35 BMI up to 50. When we reach 50, we consider eventually malabsorptive procedures in 1 or 2 stages, like sleeve plus SADI. So this could be a strategy. But if we are under the 50 BMI as an indication, for example, we like to place there the gastric bypass. I think it's very important when we discuss with the patient about his journey with the bariatric surgery is to understand how many procedures she will be or he will be allowed to have. And this is very important because a lot of patients went to the sleeve gastrectomy thinking that after a sleeve gastrectomy, there would be a bypass in case of insufficient weight loss or weight regain. But the thing is that the second steps are not always as effective as the first steps. And that's the reason why, for example, we are performing a nice study in BMI 50-55 to do sleeve or SADI in 1 or 2 stages. And so the person who gets a gastric bypass must understand that there's usually nothing else after a gastric bypass. It's like when you want to afford to buy a car and you spend a lot of money in the car. Yeah. Maybe we will change the color and we will change the wheels, but we won't be able to change and renew completely the car. It's very important for us to make sure the patient has no drug abuse, alcohol abuse. This is very important because we can have very serious problems, and make sure the patient won't have any abuse of sugars. We have faced also, and maybe you have read about them, long series of reversals of gastric bypass. We have published with Dr. Himpens, but also in my institution, more than 25 cases because of the hyper excess of sugar after gastric bypass. And this is a deal for the patient. No? Smoking can be a huge or relative contraindication for marginal ulcer. I think this is something to be aware of in this type of patients, but definitely it should be a patient maybe that has some metabolic patterns. But I would say BMI 42 with no comorbidities for us nowadays is a gastric bypass, as far as the patient understands all the comorbidities. Other clear indications are when there's the presence of hiatal hernia, esophagitis with GERD, for example, type B. These are patients we like to stress the interest of avoiding a second stage sleeve to bypass or reversal. Even if they ask for a sleeve gastrectomy, we must make sure they understand that there's a high risk of long-term esophagitis that will turn them to a gastric bypass. These are some features of the gastric bypass, but I think it's a technique that has very good indications, even in BMIs with 35, 40 with some comorbidities. I mean, the gastric bypass, if it's tailored and it's not a distal gastric bypass, can give a high quality of life and a long-term maintenance of weight to these patients.
Sir, excellent. And you have explained in detail. Sometimes we face some post-menopause female patients with symptomatic osteoporosis. So as you know, definitely when we do any type of bypass, there will be some type of micronutrient deficiency. How do you deal with these patients?
So these patients usually, if in the postoperative care and in the mid-long term, they have no clear symptoms of malabsorption like diarrhea, steatorrhea, because this could happen. That's the important thing of measuring all the small bowel and tailoring it. Because if you do a gastric bypass of 1.5 meters and 1 meter, and this is 250 for biliary and alimentary, and maybe the patient has only 4 meters, you've done a very short common channel, and the patient suffers from malabsorption. And it's true that in these ages, you can have some deficiencies, and you have increased PTH hormone to supplement that has to be compensated. In some occasions, we have had to reverse the gastric bypass in terms of shortening the limbs. to avoid malnutrition. But I think with a standard gastric bypass with accurate supplementary nutrition, it should be feasible. I think we must not go to the malabsorptive procedures like SADI or AGB that can be stronger in terms of malabsorption, and they need clearly persons who can afford to buy the vitamins that won't have sugars, which is something, for example, in the Middle Eastern countries is something very important in terms of cultural. No? I mean, in some way, even hypoabsorptive procedures in your countries could have problems, no? Because if you have a lot of sugar, you have a lot of glucids, you can have some complications for these patients, you know, with the hypoproteinemia, edema. So this is important, but we are not usually too aware of these complications, even in the elderly patient.
Definite, sir. So definite in a technical session, we will talk about BP limb length and how we select. Sir, another question regarding your pre-op upper endoscopy or gastroscopy and H. pylori eradication. What is your protocol?
Okay, so we systematically do a gastroscopy. If the patient clearly does not refer any kind of reflux or symptoms, because, for example, he's young, at least we do a barium swallow to understand if there's passive reflux or hiatal hernia. But we do always check the Helicobacter pylori. We think, although it's controversial, that we need to eradicate the Helicobacter pylori, especially for patients going to gastric bypass, because it's clearly related to marginal ulcer. Of course, the marginal ulcer can be promoted by other factors like tobacco, for example, or an ischemia in the postoperative, or a stenosis in the postoperative care of the patient. Ischemia, stenosis, this means marginal ulcer, but if you have tobacco and Helicobacter pylori can be factors. But we like to eradicate the Helicobacter pylori. Its presence is not, the literature is not 100% convinced that this is strictly necessary, but we like to do it, especially for undergoing gastric bypass, definitely.
Excellent.
Yeah.
Regarding Rowan gastric bypass, have you any age limitation, like in adolescents or older age, when age is 65 plus, so they less tolerate malabsorptive surgery? So what is your practice?
So what we specifically do in young people is we avoid hypoabsorptive procedures. So we only go there for sleeve or gastric bypass. And in the elderly, for our institution, the public health system covers up to 60 to 65 years under protocol. After 65, the public health system doesn't pay any procedure. In the private practice, it can be considered, and then we must focus in a very strict way with the endocrinologist the possibilities to supplement the patient. If the patient has clear indications for gastric bypass, for example, assuming that there's a hiatal hernia and esophagitis, maybe the patient has already some diabetes treated with anti-diabetic pills, we can offer him a gastric bypass because we are solving everything, but we will take care into account the limb lengths. This is going to be very important. For us, it doesn't make any sense not to do a gastric bypass in a 67 years old lady with esophagitis grade B and a hiatal hernia. It doesn't make sense to make a sleeve just because it's going to be better for the malabsorption. It's going to be a problem for the GERD. So, and we do oncologic surgery, laparoscopic in 75, 80. So there's no clear reason of the problem is to understand the patient is not only the surgery, but is also the nutritional, the psychological, and the activity, and the possibility to understand and to join a multidisciplinary program. This is very important.
Yeah, thank you, sir. Sir, regarding, because now we will touch a little about some technical points in this session. Every person when start surgery anytime, any type of surgery, so there is some evolution in technique for better results. So we are interested to hear from your side regarding Roux-en-Y gastric bypass. Now more than 1 decade, you are practicing Roux-en-Y. Can you highlight those points? Yes, I must do like this, and this will be better results, less complication.
I think we have changed completely the the way to do our gastric bypass. In the beginning of our experience, that was when I was teaching, we were doing the reinforcement of the lesser sac, so the remnant. We were doing the reinforcement of the complete pouch. This was something very interesting, and we were doing a double layer of the gastroenteroanastomosis defect. At the beginning, we were not closing the Peterson because my old chief was not aware of the situation and the technical feasibility. So this is something we completely changed since more than 8 years ago. And what we have always been doing is the simplified gastric bypass, in which we convert the final omega loop to a Roux-en-Y gastric bypass when we do the transection of the gastroenteroanastomosis with the Roux limb. Things that we have changed, we have moved to non-resorbable sutures. So we don't use non-resorbable sutures. I think this is very important. I think it's very important to avoid any kind of suturings that can even give more time to the surgery, like, for example, single stitches to the corner. So if you are very aware in suturing, you can do a simple coming from the top to down suturing by suspending the alimentary limb, reinforcement of the lateral pouch, closure of the defect, and you simply do. So now, for example, I am doing only one layer. In Belgium with Dr. Himpens, where I trained, there was the suture was not, so there was a suture coming from down to top and top to down, and it was not in the middle. We used to put the NG tube, and then we were pulling from one side and the left side to calibrate the anastomosis. This was a very interesting, but again, only one layer of VDS 2.0. And I think this type of sutures can be very, very confident. In marginal ulcer, we have learned that we need to go to completely manual anastomosis. So we do a posterior layer of resorbable suture opening and 2 layers of non-resorbable suture 3.0. And this should be perfect. So you avoid foreign material like the staplers. And it's the same suture we do in robotic surgery. All the bypasses in robotic surgery, I completely hand seal. I learned also in Belgium for 3 months, I spent with Dr. Dillemans, the circular trans-abdominal anastomosis. I don't perform it. I know how to perform it. I would say I would be able if I had this thing in the OR, but I think it's a very nice way to calibrate. It's very fast. Then you can put two small goodnight stitches. We used to call them goodnight stitch. So it's very easy. And I think we have moved to a closure of all the defects. I think this is important. Of course, we can have the controversy hernia versus intraoperative complication. And I think this is a great debate, but we feel more confident by closing all the defects. And another thing we used to do, it was a stitch from the alimentary limb at the beginning to the remnant stomach to put better this is something we really don't do anymore. I think a lot of surgeons worldwide don't do it. And another interesting thing for our young surgeons we can recommend is first to check if the small bowel will be able to go up in what they think is going to be their pouch. This is very important. Don't do a pouch if you are not sure your limb will come in the upper part of the supramesocholic area. Always divide the epiploic fat in order to have a smaller distance between the meso of the small bowel to the pouch. Avoid considering transcolonic. If you are a young surgeon, transcolonic approach, I mean, it can even be more difficult, no? But just think about these things. And if you can do the pouch, the smaller you can, the less acid you will have, it's going to be better. But don't suffer to do a small, longer pouch to have a more comfortable anastomosis, especially in your beginnings. If the patient is complex, the small limb will have difficulties to be pulled. Maybe your assistant will pull too much. You will have some small holes, and this can be a very big mess for everybody. But I would say small pouch, well calibrated, calibrate your anastomosis. If you can do one layer is fantastic. If you want to do 2 layers, be careful not to be too stenotic. always calibrate the tube. You can do a double check of the both anastomosis with methylene blue and green indocyanine if you have the camera, and then you cut and you divide the omega loop to the one Roux-en-Y gastric bypass, and we close the defects. This is our standard bypass. It takes us around, if we operate the standard team from 55 to 1 hour to 1 hour and 30, depending on the case, usually. We feel comfortable in this side. We prepare very well the patients with the diets. I think this is very important to avoid major complications with huge livers. And I think this is the effort of the team and the dietitian. Yeah.
Sir, excellent, excellent. And in detail, sir, what is the size of your gastroenterostomy?
So we calibrate with a 36 or 40 French bougie. We like to go, if the surgeon feels more comfortable or reinforcing all the pouch, then I would suggest him not to pull too much and to be very not to be very tight as far as he will reinforce. If you do a standard pouch with standard commercial staplers, which we can say they are secure enough, and you respect the fat pad at the area of the his angle, and you feel that the transections are nice and won't get ischemic, then you can do a nice pouch. Should work properly in these terms. We always put the camera slightly towards the right at the level of the esophagus. So we avoid the round ligament, and we know that the 0 degrees of the camera, although we work with 30, is our axis of the esophagus. So it's very easy in some way, if we don't have any hiatal hernia, because we know it from the preoperative time, where it's gonna be our retrogastric passage to the diaphragm, and this is very important. We always dissect a little bit in the upper part, and then we put a compress, which is a good recommendation for younger surgeons in order to avoid complications with the spleen. If they are a little bit, they have some stress, let's say. And if your assistant is very trained, he can use his left hand with the 5mm stroker in the epigastric also to pull under the stomach, and to allow you to have two hands while you are pulling under the stomach and doing like a sort of cave and showing very well the short vessels. I think the assistant can do part of the bypass if he's very well trained. He can show you exactly what you have to do. That's very important as a trick.
Sir, excellent. So, sir, next question, that is, I don't think we can standardize till next decade, that is the BP limb. So what is your standard? So when you are going to select BP length in a specific patient, age of patient, BMI of patient, and comorbidities. So all things are important for you to standard for patient.
Yeah. So what we do is we classify the patient. So the bypass, we will have a bypass in patients ranging from 35 to around 50. Over 50, we try to think in two strategies. Even if 55 with a Barrett esophagus, for example, we'll do a sleeve and we convert it to a bypass in 6 months. But if we have this BMI, then we will try to classify the patient into his metabolic condition. If we have metabolic comorbidities, meaning steatohepatitis, NASH, especially diabetes, and central obesity, especially more in males, but we see that also in females, then we try to do a longer biliary than alimentary. We do minimal 1 meter of alimentary, and we can even do 140 for biliary. So this would be around 2 meters and 50 of excluded small bowel. And depending on the BMI and the height of the patient, we can try to think, but we check the common channel to avoid malabsorption. So usually this is for the metabolic patient. So we try to do a long biliary limb, higher than 1 meter, 1 meter 20 centimeters. But if the patient has no comorbidities, but the indication, for example, is the presence of GERD, reflux, hiatal hernia, we can do a standard gastric bypass with a biliary of 1 meter and an alimentary of 1 meter, 1 meter 20. So these are the main situations.
Sir, excellent, excellent. Sir, regarding If we talk about hiatal hernia, if someone is suffering with also hiatal hernia and large size hiatal hernia, are you prefer to repair hiatus?
We always repair the hiatus. I think when you have hiatal hernias bigger than 4 or 5 centimeters, even of 2 centimeters, as far as we see part of the stomach going inside the thorax, because we feel that the hiatal hernia is present, we feel the pillars that are going inside the thorax, we always repair the hiatus. I think it's very important. Even for doing a good pouch. So we repair the hiatal hernia. This is a quite feasible maneuver. It takes 10-15 minutes, let's say. It is very easy to do as far as you control very well the pillars, and it's the way you're gonna be doing a nice pouch. So you can start doing the correction of the hiatal hernia and then doing the pouch and finishing the correction of the hernia once you are performing the last stapling of the pouch. What we have seen in these patients is, because we think from a short esophagus, is a migration of the pouch again in between the closure of the hiatus. We have seen that in 3-4 patients, so we have had to repair the migration of a pouch in the thorax after gastric bypass with previous hiatal hernia repair. This is a very interesting situation because the patient complains of pain, again reflux, and we do an EOGD, and we do see like a sand watch and a sand clock in which the stenotic area is the closure of the pillars. In these cases, we do again the hiatoplasty, and sometimes we do an anti-reflux to support better that, which is a teres procedure in which we take the round ligament and we do a sort of pillow with a round ligament between the hiatus and the pouch. It has occurred. In another occasion, recently, for example, something we learned with Dr. Himpens, we did a funduplication with the remanent stomach. So you dissect all the pouch, and then we do a funduplication with the remanent stomach. These cases were sometimes done primary. So this is another option, and it can be an option for patients in which you consider it needs more metabolic effect of the surgery and you want to put the patient in OHGB, but has a hiatal hernia. You repair the hiatal hernia, you do a long and thin pouch, you do your OHGB, but then you do application with the remanent stomach of the upper part of the OHGB. Can be a strategy to deal with the GERD and OHGB and gastric bypass.
Excellent. Sir, also I have talked because the same question with the Professor Bruno Deleman. So what he is doing routinely, initially when someone is suffering with hiatal hernia after hiatoplasty, always he anchor this gastric pouch with remnant, not with the crura. So sometimes they do this fixation or gastropexy, but what he explained me, so routinely he do this because as you have mentioned, yes, maybe there will be migration. So now, as he mentioned, routinely he this gastropexy or this pouch again with remnant, and this remnant hold inside. Not this fundoplication, just fix this.
Fixing it.
Yeah. Then this remnant, this pouch will not migrate.
I've seen his technique, and I think it's very interesting. I mean, definitely the strength and the pulling of the remanent stomach is higher than doing a pexy or even a heel procedure in which you go to the pars aortica. But we've done that with very poor results, definitely.
Yeah, it will be good. Sir, you have mentioned regarding closing defects. Already you have mentioned. We are interested to hear from your side which technique you are this close with the interrupted sutures or no pierce suturing. According to your experience, which one is better?
For doing the gastroenterostomy, you mean?
No, sir, for closing defects, that Peterson or JJ.
Oh, what we do is, I think there are two situations. First, the technical aspect for the younger surgeons. It can be one of the most demanding steps, no? Because if you have a long patient, if you put the trocars very high, you will be very comfortable for the hiatus and the gastroenterostomy, but then you will be very uncomfortable for the Roux-en-Y and for the Peterson. So you need to find an equilibrium. So you are very interested in having clever suturing, like barbate suture. So the suturing that has the little tails that doesn't allow any feedback. Another possibility is to do an extracorporeal knot. It can be a very interesting thing. So you go around all the meso defect, very close to the upper part, and then you do an extracorporeal knot with the Prolene 2.0. This is something I learned with Dr. Himpens for the hiatus, and I train my residents in knowing how to do an extracorporeal suturing. The problem of the extracorporeal knot is that where you knot it, usually you end the suture. So if at the end you are not happy with the end of the suturing and you would like to do another or two more, it's a little bit more complex because you need to put again the needle inside.
Yeah.
And it's a long suturing. I mean, it can be a little bit complex, but I think it's very important to understand, for example, the mesos, if they are very metabolic, they can break very easily. Closing a mesenteric defect can be challenging for young surgeons, especially if they have some bleeding. It's very important to stress the possibility of avoiding bleedings of the mesos. I think this is very important. And then any type of suturing that you will feel comfortable. Some authors have described to do with staplers. I have no experience with staplers, but I think I think that you need to do a suturing, and we close both of the defects, usually going from bottom to top, the more difficult to the more easier, in which you control the area of the colon, the mesocolon, and the meso of the alimentary limb.
Excellent, sir. Sir, now we will touch some questions post-op. So according to your protocol and experience, how you follow your patient, especially upper endoscopy? Is it routine or only in symptomatic patients?
No, we in the postoperative care, we don't follow the patients with endoscopic after gastric bypass. Only for those patients who refer epigastric pain or any kind of symptoms that would suggest us any GERD. Usually this can account so they stay on PPIs for 6 months. And after 6 months, we remove the PPIs. If there's any kind of epigastric pain symptoms, we try to differentiate the possibility of having differential diagnosis with the possibility of having hyperchlorhydria and reflux, marginal ulcer, but also any problem of cholelithiasis. Sometimes you can have some kind of cholelithiasis that can occur during the first half year or first year because of the weight loss and on the gallstone formation. In these cases, we can do maybe a gastroscopy, or we would start with a barium swallow. What we also like to check is that the times that the patient had to move from liquids to puree to standard meals during the 2, 3, 4, 5 first weeks after surgery, we don't have any symptoms of stenotic anastomosis. If the patient vomits puree and is unable to eat some egg or some omelette or some bread, we need to be aware that there could be a stenosis. And we must check if this is the reason to do an endoscopy for dilatation. In these cases, we will be more aware of long-term complications of terms of marginal ulcer, but routinely we don't do gastroscopy in this type of patients, only specific pains, situations, or something that we were looking because there's a complaint from the patient.
Sir, which percentage of your patients are suffering with the marginal ulcer upper Roux-en-Y gastric bypass?
Less than 3%.
Yes, then. And earlier you have mentioned for H. pylori eradication, and
yes.
According to your belief, you must eradicate maybe in future due to H. pylori. So this 3% or less than 3%, how much patients were positive with H. pylori before surgery?
All were positive. They were apparently eradicated, but they can have reinfection. So again, after bypass with the possibility of having ulcer, we need to find out any intolerance of material, linear stapler. So our anastomosis, most of it is linear stapler with calibrated at 3 centimeters and then closure of the defect. So possibility of Helicobacter pylori, of having had any ischemia or stenosis in the postoperative, or tobacco. So we have to recheck and re-eradicate Helicobacter pylori. But you can have Helicobacter pylori negative, and this is due because he's a heavy smoker. 2 weeks ago, we did a re-anastomosis of a girl with a BMI of 25, but she smokes, and she had a 1 centimeter marginal ulcer.
Yeah,
so you need to find the factors.
Sir, yes, I understand. So one of the factors, because this is message for our youngsters. If someone is heavy smoker, please be careful. There is more chance of marginal ulcer. If someone is H. pylori positive, eradicate. So you will be in safe zone. Sir, my question, because so have you any comparative study between this hand-sewn gastroenterostomy and with stapler? Because what is your belief? When we use stapler, there will be foreign body and there will be more chance of marginal ulcer. So have you any comparative study when you do hand-sewn with absorbable suture, there was less chance of marginal ulcer?
When we do hand-sewn, there's a less chance of marginal ulcer. The problem of the hand-sewn is that the calibration can be very better compared to linear stapler. And the problem of linear stapler sometimes is that we have more stenosis, because we although we calibrate, sometimes we try to close it more. These are the features of the thing. And then the linear stapler is more related to bleeding compared to hand-sewn. So this could be a difference when adopting the anastomosis. I think young surgeons need to know how to do a linear stapler, which is the most, well, it's more comfortable. Maybe circular also, but you need to be aware of doing very well the closure of the anvil inside the stomach. But definitely they need to know how to do hand-sewn fully anastomosis. I think this is important for young surgeons in emergency situations, but also for anything.
Yeah, excellent. So regarding this, because you have mentioned, so intractable marginal ulcer, and just recently you have revised anastomosis. So she was a heavy smoker. Maybe again she will smoke, and again she will suffer with marginal ulcer.
Yeah, but now she has dropped the tobacco. She is advised, and I think it's a shame, no? Because even in our public hospital, smoking is not a mandatory condition for not being accepted for the surgery. But some hospitals do have that, and the leak rate is increased in smokers. So I think it's important also to reinforce this point to the surgeons. I think going bypass, smoking, alcohol, and sugar are very difficult situations if the patient is not aware that this can have problems in the mid-long term.
Yeah, definitely. Sir, another issue after Roux-en-Y gastric bypass, because in Roux-en-Y gastric bypass, our main component is restriction, not hypoabsorption as compared to OHGB. So which percentage of your patient are suffering with weight regain?
Weight regain, we are facing weight regain in 10-15%. What we've seen is that some of these patients we have seen, and that was published in Obesity Surgery, that was in June 2020, about the COVID pandemic. The COVID pandemic has led to an increase of the weight in the overall patients due to the lockdown, but also other situations like anxiety, psychological disturbances. But these patients are mainly patients that either the technique was not suitable for them, either the technique, they didn't understood the importance of taking care of the bypass in the mid-long term. And I will try to differentiate the patient that we have two types of patient. The patient that doesn't lose correctly the weight, so it's a patient with insufficient weight loss, and the patient that has had a good result after the surgery, ranging BMIs around 25, 27, 30, let's say 30, at least less than 35, but has weight regain. I think here we need to focus and stress a lot in all the aspects related to the patient, like psychology, nutrition, and exercise. These are the things we can have for these patients. Now, I think it's very important to consider in the early stages of the weight loss, in case of insufficient weight loss, to strengthen with drug therapy, with GLP-1s, with your endocrinologist. This is very important because they can offer them a better technique. You can also consider that you tailor not correctly your bypass. Maybe the patient has 7 meters, you did 1.5 is 3, but he has a common channel of 4. And this is a lot. And if he has too much sugar and he doesn't do any kind of exercise, it's a patient that can suffer weight regain. And it's very important in these patients in the preoperative work to make sure they understand that this is a car forever. We won't change the car. We don't have a second bypass. So this is a very good opportunity. This is a very good technique, but you need to understand it. I think the possibility of doing an OHGB, although the simplicity and the problems of the reflux, the biliary reflux and all these things, is that it has some more potential in resolving malabsorptive procedures. In patients with even higher metabolic conditions, we even do OHGB, even better than gastric bypass. And we accept the risk of converting the OHGB to a gastric bypass in the mid-long term in case of biliary reflux. This is something we have the feeling OHGB is much has more intensity in resolving the patient and in maintaining the patient. So for me, it's a very interesting procedure also.
Sir, in your experience, have you any patient suffering with intractable dumping? No, nothing, diet protocol, everything, it was not effective. And if you have, what you did surgical intervention in such a case?
So what is very important is to make sure first to diagnose the patient. So we do the test by the taking 100 grams of sugar. We do the insulin levels with the glycemic curves. Once the patient is diagnosed and we are clearly understanding he has hypoglycemia that usually occur after 1 year, 1.5 years, usually in patients with too much sugar, we reconduct all the hygienic patterns and the nutritional patterns to the patient. We can add the Invokana, and then we did a couple of publications with carbagocicina, 300 milligrams, which is a drug that can tamponate some way the problem. If this persists, we need to consider the reversal of the procedure of the patient. Then is when we do the reversal to normal anatomy or to sleeve gastrectomy, depending on the BMI of the patient. This is a major procedure. It has also been described to convert the patient from a hybrid mixed procedure like the bypass, convert it to a restrictive procedure or a sleeve, and the sleeve to a malabsorptive, SADIS or BPDDS. But this is a very tough path for a bariatric patient in which it's maybe not sure it's going to work. You need to understand what is happening with the patient, making sure there are no problems in educational, nutritional, and psychological. But this is a very heavy. But for the hypoglycemia is the reversal. Definitely there are a couple or 2 or 3 papers published on that. And specifically one with 16 patients we published with Dr. Himpens, explaining the technique when you want to maintain or not the alimentary limb. If the alimentary limb is higher than 1 meter, 1.5 meters, for example, I think it's convenient just to resect the upper part of the anastomosis and to disconnect the biliary limb and then reconnect it with the old alimentary limb. Like this, you do again the small bowel. So you have a gastro-anastomosis. You can do the sleeve or not, but you have a gastro-anastomosis, and then you have a transection of the biliary plus an anastomosis on the biliary with the alimentary.
Yeah, definite, sir, definite. And if so, this will be just a rescue surgery for
Yeah.
such a case. Sir, this is just like a personal question. Now, at this stage in 2022, which percentage of your bariatric surgery belongs to Roux by gastric bypass at this stage?
Yeah. At this stage, I would say more than 70%.
Oh,
Six,
excellent.
70%, I do 10%, 15%, 10% sleep for very low BMIs, 35 with no comorbidity young patients, very young patients, 25, 22, but and then 15% revisional surgery at least.
Excellent. And also in your percentage, there is some space for OAGB.
Yeah, OAGB would be, so in the 70, around 5% would be OAGB. So the OAGB in my institution is not clearly introduced, and I do in my private practice. I think it's a very good procedure, but you need to follow them in a correct way, but they can have very good results, definitely.
Excellent, excellent. Sir, now just so for my viewers, I am talking with someone whose main practice is Roux by gastric bypass, and definitely this will be one of the best session. Sir, at this stage, after this experience of more than 1 decade, what is your main concern of Roux by gastric bypass after Roux by gastric? What is your main concern?
My main concern is when you work with the patient for the first time, is to understand that this is a sole procedure. There's nothing worse than having insufficient weight loss or weight regain after gastric bypass. It's really a shame, and some patients, when they come back after 2 years, we do the follow-up every 3 months, and after every 6 months, and after 2 years every year. But when they come and they said, well, I have not done very well the things, and I knew it, and now look, I took back 15 kilos and I'm back in BMI 37. What can we do? It's a shame because you do an OAGD and you see the bypass is nice, the pouch is small, the anastomosis is not too high, there's no hypoglycemia, and there's very few to do. Resizing the pouch, putting more restriction in the anastomosis, banding the bypass, changing the limbs, the measurements of the limbs, but these have very small impact in the final loss of weight. Maybe they will lose 5-10 kilos, but they won't lose 20 kilos or 30 kilos. I mean, the second parts of the movies weren't so good. And after a gastric bypass, it's a shame to say it. So we need to do a lot of psychological, educational, and maybe drug therapy with the endocrinologist. So this is one of my big concerns. In technical aspects, my big concern is to calibrate very well, not to leave too stenotic anastomosis, too tight anastomosis to do ischemia. And then the other things is, I think doing a bypass is a very sympathetic procedure. I mean, it's sympathetic, the retrogastric. There are some main complications intraoperative. I think is the management of the small vessels at the level of the spleen. And in the postoperative, if I had to choose, I prefer 3 leaks of a bypass than a leak of a sleeve. So the leak of the gastric bypass can be a complex situation, but you have technical aspects. Well, you can do relaparoscopy, consider stenting with some comfortability compared to OHGB, for example, that you first go to a gastric bypass and then you do the stenting. But leaks in the sleeve for us has been a torture. I mean, we have received long chronic leaks, even going to the lung with gastropulmonar fistulas, and this is a very complex situation. The gastric bypass, if the gastric bypass goes well, the second day he's out of the bed, he feels very well, he's having his liquids, and you can even do it with 1 night surgery. We do 2 nights, but some bypasses are they go very well. I mean, they don't have nausea, they don't have vomiting. This is very different from the sleeve gastrectomy.
Sir, your main bypass is anticolic, as you have mentioned, but also have you experience of retrocolic, like HIGA?
You mean to pass through the retrocolic? No, only for the ones we have had. So in Spain, at a certain time, there was the retrocolic, open retrocolic and banded gastric bypass. So that was a fovicapella, open fovicapella, and we have had to convert them to a gastric bypass. So by dissecting all the upper part, cutting above the silastic band, dissecting the pericolonic and transvasogastric, and then putting in anticolic. But this is revisional surgery. I've seen doing it. I have assisted persons doing it. I think you have to be aware with the medium colic vein mainly. But it's very rare. So my recommendation for young surgeons is to make sure if select the first cases. The first 20, 30 bypasses must be very easy. So BMIs 40, 42, women, peripheral obesity, non-central obesity, no steatosis, no metabolic pattern. So something very easy. It's very easy. This bypass is very easy. So let's do it. So, but check if the small bowel comes in. If your assistant pulls too much, he won't break the alimentary limb or the biliary limb. So these type of cases, in order to get trained, but always be sure that the small bowel will go up. Otherwise, you can have problems. Yeah. Especially if you are young and you don't have any other alternative thing for the intraoperative situation.
Yeah, sir, you have mentioned regarding this bend-in gastric bypass. Is it your routine nowadays?
No, it has never been our routine, but it was the routine of my chief when they used to do open surgery. So at that time, they were doing the anastomosis and they were putting a banded ring of polypropylene mesh or silastic. So this is like a plastic or propylene mesh. And these are very bad situations because in the long term, the mesh gets involved and there's a stenosis of due to the bandit. And the endoscopy is unable to open it. So you need to cut it and convert it. This is like a VBG, historical VBG, which there was no small bowel, but there was a vertical banded gastroplasty and a lot of problems, and you need to cut the remnant, the cut under and above, and do a bypass. There's a group of surgeons, the two brothers in Spain, Dr. De La Cruz, who have published a lot of the banded bypass. This is something they learn as a concept of avoiding the long-term dilation of the pouch. And this is, again, what Dr. Dillemans is proposing, no, for his gastric bypass. Why don't banding it? Some surgeons have put it an adjustable gastric band, which is something interesting, no? But they have used it with silastic, but also with adjustable gastric band. And the more crazy things in some way is banding the sleeve. But this is something that has also been described, but in which obviously I don't do. But for a bypass, it can be something interesting. It can be a measure for the revision. If you cannot do a pouch trimming in a revision and doing again, going back to the principles, restriction, malabsorption. So doing a smaller pouch, a smaller anastomosis, avoiding the candy cane, resecting the candy cane, for example, and you do a pouch trimming from down to top, and then you reinforce everything with a bougie, put it inside. This is the more you can offer to the patient. You can do that endoscopically, and you can fulgurate with argon the anastomosis, even for the treatment of hypoglycemia. You fulgurate and you do again the anastomosis smaller, and this allows you a slower passage of the sugars, but also the food, and endo pouch plication with endoscope performed by bariatric endoscopists. They can be doing that, and this is kind of interesting with Apollo technology.
Yeah, sir, excellent. Sir, regarding, you have mentioned, you have termed this was interesting for me, historical VBG. Mm-hmm. Also, we have historical bending, and also progressively we can see sleeve gastrectomy is literally going down. And nowadays, so OAGB is coming up. and now ASMBS also recommended. If so, recommended, and maybe in future, how you predict the future of Roux-en-Y gastric bypass?
I think the Roux-en-Y gastric bypass will continue to go ahead. I think in 10, 15 years, we will be able more to tailor better our patients. I think we will be able, as for example, we are doing in our institution in major studies, we are doing genetic study of the patient with some specimens from the mouth with the saliva, and we try to find out the predisposition of weight loss, and even now in patients with weight regain. So we will be able to tailor better our patients, saying, look, your obesity is very hereditary, so you need a more intense procedure. We will be able to tailor better our gastric bypass by understanding, maybe with some type of fluorescence, with where do we need to do our bypass, understand better the role of the alimentary limbs. I think we will be better, we will understand better our gastric bypass with the good signalization, with the microbiota and also the bile acids. So I think all these will come to promote a better gastric bypass. It's a shame, but we have no standardization of the gastric bypass. I think there's a paper, I should find it, but there were like a funny description of more than 100 types of gastric bypass. So we talk about gastric bypass, but everybody does his own gastric bypass. Yeah. Obviously, it has a pouch, it has an alimentary limb, it has a biliary limb, it has a common challenge. No one measures all the small bowel. We don't know how to measure. It's very complex. It's a shame because we have mainly 3 procedures, but it's not really standard, no? And this is one of the criticisms we receive from our colleagues of the endocrinologists. But the gastric bypass will be there. The sleeve will decrease from my point of view in the mid-long term. The more we will see the reflux and the stenosis, the more we will have less sleeve going on. But I'm sure the OHGB will have a major role in the future. Definitely.
Yeah. Sir, excellent, sir. Sir, so because we have a lot of viewers from all over the world, especially in Middle East, South Asia, and this region, what is your message for these youngsters who are just going to start bariatric surgery?
Well, I think they need to train hard. I think they have a lot of possibilities to have training in through different networks in their countries. Definitely, their own national societies, which are related to IFSO, must offer them the possibility to get well trained. I think they don't have to be frightened to move from their countries for short periods of time in high volume centers, or with experienced centers to do some more training, to do even more, some research and publications. I think it's very important they study a lot and they could at least assist to their national or any international chapter meeting. I think this is something important, and why not the World Congress? And then when they start and they face a learning curve, they start with easier cases. And I think they need to know how to do at least 3-4 procedures. I think a pure bariatric surgeon can be able to offer the best procedure to each patient. And I don't agree at all that you only do OHGB, you only do sleeve, or you only do gastric bypass. You can turn somehow in your protocol to more a procedure or other, but they need to get in high skill training in order to not only to do the primary procedures, but doing and solving their own complications, which is something very, very important. But I think there's a lot of possibilities to get trained, and then going with expert surgeons, which are serious, and they work in a very multidisciplinary team and with very important protocols to understand that the patient has an intrinsic complexity. You know, it's not like a cancer. For example, I remove a thyroid, it's analyzed, but I don't care if it smokes, it drinks, it moves, it eats milk or not milk or yogurts. I mean, our patient and our results depend on so many other things, and this is very important to get understood. There's nothing else easier than operate a patient, but I think it's very important to put the patient on the OR in the best position for him, especially to have very good results in the mid-long term.
Sir, so much thanks really, and for your time, and definitely it was one of the best session, and definite for our viewers, this was very fruitful session. Sir, in future also we need your support, and because so from July we will start metabolic surgery in low BMI, and in 2023 we will talk about redo surgeries.
Okay.
And definitely in future also we need your support, and my viewers, so much thanks for your support, and all of these sessions are due to your interest. If you have any question, you can ask in comments, and personally you can ask myself. Sir, again, so much thanks for your time, and
Thank you very much.
hope see you soon in any international event.
Okay, thank you very much, and I hope to see you soon. It has been a pleasure for me. Thank you very much.
Sir, have a nice time.